Hello and welcome everyone. I'm Tina Walia and I'm pleased to be your host today. This evening, we are excited to present the latest in our webinar series on wellness, Heart to Heart, exploring the spectrum of heart disease. We acknowledge we are hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and the Inuit peoples. Here are a few webinar reminders. To submit a question, please type into the chat window. If your question has already been answered, please delete it from the chat. And everyone attending this webinar will be in listen-only mode. The Ripple Effect Wellness Organization, or TRIVO, was founded by Dr. Sudhi Devanesan and Mr. Ravi Juneja in 2009, with an advisory board of eminent personalities like Dr. Manish Maingi, Dr. Salim Youssef, and Ms. Jennifer Lin. Our mission is to create healthy communities through education, which we strongly believe is the best preventative medicine that one can have. We host a number of events throughout the year, such as the Gala, Golf Tournament, and Youth Summit, in addition to the webinars brought to you by the Women's Outreach Wing. The Women's Outreach Wing, or WOW, is a branch of TRIVO, and we have been serving our community for well over 6 years. Our mission is empowering women through education, and we do this by inviting, inspiring, and motivating speakers to empower and educate our audience on topics that contribute to the wellness of women, their families, and our communities. I think we're having a few technical difficulties this evening. I think Zoom is giving us a few technical problems. So we're just working through the problems. Just give us a minute. I'd like to now introduce Dr. Sudhi Devanesan, or Dr. D, as he's affectionately known as the president of TRIVO. Dr. D is a family medicine physician, an educator, and a public health activist. He was inducted as a member of the Order of Canada in 2001 for his role in health and prevention of heart disease among South Asians. He has also been the Chief of Department of Family and Community Medicine at St. Michael's Hospital. Over to you, Dr. D. A very warm welcome.
Thank you very much for that introduction, Tina. And I really want to welcome all of you to this wonderful webinar we're having. And we're just so happy that we could do this thanks to the Women's Outreach Wing, who have worked very hard to bring these webinars to us on a regular basis. So I congratulate Smita Chandra and her team for doing this. And I'm very grateful to Dr. Manish Maingi for accepting our invitation and speaking this evening on a very important topic on prevention of heart disease. Thank you so much, Manish. The Ripple Effect continues to work hard to try and bring education and empowerment to our communities. In doing this, we also do some fundraising activities, which we hope we can restore since the pandemic. Today, I want to introduce another word with a lot of meaning. And that is a Tamil word, my own mother tongue. And that word is pasam. Pasam means enduring love, friendship, fellowship, and a closeness of being tied together in ways that are profound and far-reaching, especially during these difficult times when we've experienced isolation from our loved ones when we have experienced loneliness, even in a crowd, and mental health problems are on the rise. Possum is the word that comes to my mind that binds us together, brings us together, holds us together during these difficult and troubling times. So remember the word possum, possum, and please apply it to your lives. And I'm sure all of us can do with some possum. And now I hand you back to Tina.
Thank you, Dr. D, for continuing to enrich our vocabulary with your wonderful words and your amazing stories. So today's presentation is about heart health. And in order to understand our audience better, we would appreciate if you could please answer this poll. Does your family have someone who is suffering from heart disease? Are you concerned about your heart health? And lastly, are there any health professionals in the audience who are caring for people with a heart condition or illness? I'll just give you a few more seconds to answer this poll. I would like to remind the audience about the Q&A session at the end of the presentation. So kindly submit your questions through the Q&A chat box at the bottom of the screen. It is my pleasure to introduce our keynote speaker, Dr. Manish Maingi, to you all. Dr. Maingi was the chief of the cardiac program at Credit Valley Hospital from 2003 to 2013. He subsequently became chief of the cardiac program of the Amalgamated Trillium Health Partners from 2013 to 2018, and currently remains on full-time active staff. He was one of the founding board members of One Heart Care, established in 2018, now one of the largest ambulatory cardiac clinics in Canada. And he currently serves as president and board chair. He also enjoys teaching and is a clinical instructor at the University of Toronto Medical School. He's a director of the Ripple Effect Wellness Organization, TRIVO, as well as a valued advisory board. A very warm welcome, Dr. Maingi.
Thank you so much, Tina, for that very nice introduction. It's such a pleasure to be here. I just wanted to start off by thanking the TRIVO committee and the WOW committee specifically for all their work and efforts in setting this up. And it's really, really a pleasure to be here. So this talk is entitled Heart to Heart, exploring the spectrum of cardiovascular disease. So what I would like to do is share some basic themes of cardiovascular disease. We're going to talk about prevention, diagnosis, treatment, some things that are coming in the future. And maybe we can get into some further details and specific issues in the Q&A. But I think we'd like to do a very nice overview that will give you an idea of all the things that people think about when they think about cardiovascular disease. All right. The first thing that comes to people's minds when we talk about heart disease is coronary disease. So this is the big one. There are many other facets to cardiovascular illness that we're going to talk about shortly, but I wanted to start with this one because this is usually at the front of everyone's mind, and this is what people are concerned about preventing. So what is coronary disease? You might have heard the term of atherosclerosis. It's a disease process that involves the buildup of fat, cholesterol, calcium in the lining of the coronary arteries. So the coronary arteries is living tissue. They're not just inert tubes. They are lined with living cells that are metabolically active. And when those cells start to become dysfunctional, you get the deposition of cholesterol, fat, and eventually inflammation and calcification of the vessel. The endothelium, which is the term that we use for the cells that line the heart artery, are actually the target of the injury. And endothelial dysfunction is sort of the umbrella phrase that we use for the process that results in coronary disease. So when the coronary arteries become laden with this deposited material, what we call the lumen or the passageway becomes gradually narrowed. And eventually, as the lumen becomes more and more narrowed, there's just not enough blood and oxygen flowing through these vessels to supply the heart. So remember, the heart, although it's the pump of the body, also receives blood, and the heart muscle needs blood and oxygen to do its work in pumping. And these are, you could say, the fuel pipes that bring the blood and oxygen to the heart pump. So when they get clogged, the heart doesn't have enough fuel, and that's what causes symptoms of angina, which we're going to talk about. Now, this can be a gradual, slow, progressive process, but also can be a sudden process where there's what we call plaque rupture, which is when there's a crack or fissure in the endothelium, and then certain elements become exposed. Certain elements of the artery become exposed to blood. And the blood's reaction, or the body's reaction, whenever that happens, just like when you have a cut on your skin, is to create a blood clot. So if a crack happens in this plaque, you get an injury response, and you get a cascade of blood clotting, which causes what we call acute thrombosis or an occlusive clot, and that's what causes a heart attack. Now, atherosclerosis is a systemic disease. It's not just involving the coronary arteries and the heart. It involves all the it can involve many organs in the body. So when it involves the brain or the vessels, the pipes that take blood and oxygen to the brain, which are the carotid arteries in the neck, when they become involved, it can cause a heart attack of the brain, which is a stroke. So it's the same pathophysiology or the same mechanism, but just a different organ. And in this case, the artery that's becoming narrowed and potentially clotted is the carotid artery in the neck. So you might notice sometimes when you go to the doctor's office, they'll listen to the heart and lungs, but sometimes they'll listen to the neck also, because there are certain signs that we can hear on the stethoscope that might indicate there may be some narrowing there. And when there's blood flow disturbance to the legs, which is also a common manifestation of the disease of atherosclerosis, you can get reduced blood flow to the legs, and that manifests as cramping pain when one walks. Because again, when you're walking, the leg muscles require more oxygen and blood, and if they don't have it, you get the same symptom of tightness. Same thing that you get in the chest when you get angina pain. So what are the causes of atherosclerosis and coronary disease? I'm sure the audience knows that these are the primary causes. I wanted to just highlight smoking and diabetes are at the top because those particular risk factors are quite significant. They would increase your risk by 2 to 4 times the baseline risk. Cholesterol and hypertension are also very, very important. And then, of course, the toughest one, because we can't modify it, is genetic factors. And when we're talking about genetic factors, what we say is that if you have a first-degree relative that had a premature cardiovascular death, and then we define that in men as a first-degree relative less than 55, or with women, a first-degree relative that's a woman under the age of 65. So if you have a family history of cardiovascular events in the elderly, like for instance, say your father had a heart attack at the age of 70, that doesn't actually confer a statistically significant risk to you, but premature event in a first degree relative is how we define that. And of course, these risk factors, when you add them all up, actually are larger than their sum. So for instance, smoking and diabetes each have a 2 to 4 times risk elevation factor. But if you happen to have diabetes and you smoke, your risk is actually it's not 4 times, it would, it could be 6 or 8 times. It's actually multiplicative. So if you have smoking, diabetes, hypertension, it might be 12 or 14 times. So that's why risk factor control is so important. How about the other things? We talk, of course, and we're going to talk today a little bit more about diet. Of course, exercise is important. These things are studied in a different way than some of the other risk factors because they're very hard to control for in randomized controlled trials. So most of the information about diet and exercise comes from what we call observational studies, where we look at different societies, different demographics, different habits, and we follow people over time. And then we determine, is there a lower risk or a higher risk in particular populations which are exposed to different diets and different lifestyles. And this information is very useful, although fraught with certain biases, and there are some problematic issues in terms of understanding the true net effect of these environmental factors because of contamination of other things. I'm just getting a message to switch to presentation within. Sudhi, can you tell me if you can see everything clearly? I think I'll carry on. Actually, I missed one thing there, obesity. So obesity does increase your risk, and there's a particular type of obesity which is known to carry a greater risk, and that is the abdominal type of obesity. Okay? Abdominal obesity is associated with organ fat, and organ fat is associated with a syndrome that you might have heard of called metabolic syndrome. And metabolic syndrome is a milieu of physiological changes that escalate your cardiovascular risk. So when people have abdominal fat and organ fat, they also have increased risk for diabetes, increased risk for elevated cholesterol, and all of these things all obviously increase your total risk. Valve disease is another type of heart disease. In the heart, we have 4 valves. So remember, the heart is not just a, it's a pump, and it has multiple chambers, and these chambers have to communicate with each other, and the valves can, with their opening and closing, control blood flow through the chambers. So there's the aortic valve, pulmonary valve, mitral valve, and tricuspid valve, 2 valves on each side. And any of these valves can become narrow or become leaking. So when they are narrow or leaking, the heart has to work much harder. It becomes a less efficient pump. And this is actually not an uncommon type of heart disease, especially in developing countries where there's a high prevalence of what we call rheumatic heart disease. You might have heard of that, and there may be family members that you are aware of that may have had to have valve surgery. And sometimes these valve interventions are required to replace these malfunctioning valves. Sometimes we put tissue valves in, and sometimes we put mechanical valves in, and they both have their advantages and disadvantages. The other thing that can go wrong with the heart is electrical problems. So I often say a heart is like a house. It has walls and mechanics and engine room, but it also has electrical wiring. And the electrical wiring sometimes becomes frayed or malfunctions. And we see this on the electrocardiogram. So if you can see in the diagram on the right here, that there is electrical signaling that happens. The heart has a natural pacemaker of its own. And through that pacemaker, it sends a signal down into the rest of the heart muscle. And the synchronization and coordination of all the chambers pumping is dictated by this electrical network in the heart. And sometimes that electrical network fails or becomes, instead of a regular pulse, it becomes irregular or too fast or too slow. So these are all basically electrical signaling and conduction issues. Another type of heart, so we've talked about coronary disease and atherosclerosis. We've talked about valvular heart disease. And this is another type of heart disease called cardiomyopathy. And this is cardiomyopathy, just means heart muscle. It's a Latin way of saying heart muscle disease. And there are many, many, many types of cardiomyopathies where the valves are working fine, the blood is flowing fine, the electrical flow is fine, but the muscle itself, the pump itself is diseased. So there are primary issues of heart muscle involvement. One particular type of cardiomyopathy, which is only really become understood in the last, say, 5 to 10 years, is called stress cardiomyopathy. You may have heard of this in the newspaper or read about it in a magazine. It's relatively new syndrome, and we're recognizing it more and more. But typically, this type of heart ailment comes from some acute stress. It could be a physical stress. It could be an emotional stress, but usually something very severe and acute. The mechanism of this is usually related to catecholamines. So these catecholamines are hormones that the body secretes under times of stress. And these hormones themselves can have deleterious effects on the heart muscle. How about COVID? We talk about COVID, and people are very interested in how COVID might affect the heart. So COVID, as you know, is a systemic illness. It primarily affects the respiratory system, but it can also affect the heart muscle directly. So the actual virus actually can cause inflammation inside the heart muscle. I think I'm just going to stop screen sharing and restart because I think I have an issue with my screen sharing. I'm getting some messages. I think I might have it. I think I might have it. I think I was showing you my view rather than your view. So we were talking about COVID and the heart. So COVID can affect the heart directly, or it can affect the heart by affecting the coronary arteries, not by atherosclerosis, but by causing inflammation in the actual coronary arteries. And inflammation in the coronary arteries can also cause a reactive clotting. And there is some data that suggests that once you've had COVID infection, for the year after, you're at increased risk for having some sort of acute cardiovascular event, heart attack or stroke. There isn't a lot of data on that, but some of the preliminary studies over the last 2 years suggest that the rate of a cardiovascular event after contracting COVID may be up to 30% higher in the first 12 months afterwards. How about the COVID vaccine? And I get this question all the time because, you know, there is, of course, sometimes a natural reluctance to take a vaccine in some people. And when there was some media coverage of cardiovascular events because of the vaccine, then we had to really do some education about this. But it is true that the vaccine itself can create a reaction, an immune reaction, that can cause a myocarditis. So we talked before about myocardial inflammation and cardiomyopathy, but the vaccine itself, the COVID vaccine itself, can cause an immune response, and the antibodies that are created to the vaccine can cross-react with myocardial cells, heart cells, and cause inflammation and damage. Typically, this occurs in young men between the ages of 12 and 30, and typically after the second dose, because after the first dose, there's a little bit of immune activation. And then after the second dose, there's a much more robust immune response, and that could create heart inflammation. The chance of that happening, as I said, is much more common in young men. And the absolute risk in men between the ages of 12 to 30 is about 1 in 10,000. In women, it's about 1 in 100,000 of the same age group. And in older men and women, it's also probably less than 1/5 of the incidence in young men. Overall, generally, we tell people that the risk of the vaccine is much less than the risk of all of the complications that you could get with COVID, not just the myocarditis, but all of the organ involvement. But having said that, everybody, has to make a decision for themselves. And some young people, I can understand why a young man would say, my risk is only of getting serious complications for COVID is very small, and my risk for getting a vaccine-associated illness is not remote. So, somebody might choose that. But generally, the experts and the studies show us that the risk of the vaccination for all age groups is less than the risk of getting the disease. How about congestive heart failure? So people talk about heart failure. So heart failure really describes when the heart fails as a pump. So it's the final common pathway for many of the diseases. So you could have coronary disease, like we talked about, valve disease, like we talked about, cardiomyopathy, like we talked about, or electrical disease of the heart. All of these diseases eventually may lead to heart failure, where the heart mechanisms for compensating for these diseases start to run out. And it's a very typical clinical syndrome, and we'll talk about the symptoms. So these are typically the symptoms of people with cardiovascular disease. I mean, there are not that many symptoms, and they all sort of overlap. All the different types of heart disease cause one of these sort of spectrum of symptoms. So chest discomfort, of course, is a common one, especially for coronary disease. And it doesn't have to be just in the chest. Often it will radiate to what we call the interscapular region, or the upper back, the left shoulder, left arm, predominantly left. It rarely radiates to the right side. Up to the neck, all the way up to the jaw can radiate, and all the way down to the umbilicus, but usually the upper abdomen, the discomfort of angina or heart attack. Of course, breathlessness is very common in all of the types of heart disease. Palpitation, which is a sense of your heart beating quickly or very slowly, is a very common symptom, of course, of the electrical problems. And then dizziness. Well, if the blood pressure gets too low, if the heart rate gets too low, there's not enough blood flow to the brain, and that causes dizziness. If one of the common things with congestive heart failure, when the heart stops working as a pump, what happens is blood and fluid back up. So they back up into the system. It's a closed circuit system, right? So if the heart doesn't work as a pump, then what happens? The blood backs up, basically, and it backs up into the lungs, which causes the breathlessness, and it backs us into the systemic circulation, which causes the swelling, predominantly because of gravity, swelling in the lower legs. Well, this is the WOW committee that set this up, so we're going to spend a little bit of time talking about heart disease in women. And there's been a lot of research done on this, and traditionally in the 70s and 80s, we didn't really include many women in the clinical trials, looking at the effects of medication in heart disease. And even all of the diagnostic testing that was done, the test characteristics in terms of understanding how accurate and how well the test performed in diagnosing heart disease were also done in men. So there was a positive data on women. And we still haven't solved that problem, but there are now much more women included in clinical trials. So what we do know is that it does present, heart disease in women does present very much like it does in men, but there are some particular differences. One is women are a little bit protected biologically from their hormonal makeup. And generally, women are about 10 years older than men when they develop heart disease. And I often notice that in women who have a strong family history of premature heart disease in their male first-degree relatives, those women will often be protected by an additional 10 years. So if a woman has a father and a brother who both developed, both suffered a cardiac event, say at the age of 55 or 60, the woman's risk really starts to elevate at 10 years higher, so at 65 or 70. So there's a bit of a delay, which is protect. Of course, it's a reflection of the protection. Women generally get less acute thrombosis and sudden death than men, and present more with angina syndromes rather than a heart attack. Sometimes the discomfort is described differently. And in women, sometimes they don't get the same classic elephant sitting on the chest that men describe. Now, it's still the most common symptom for women, but there is a higher incidence of other symptoms. Nausea, profound fatigue, breathlessness, and chest pain might not be as predominant a symptom. What we also understand is that there's a higher false positive rate of some type of stress testing. So what that means is that a false positive means that the test is abnormal, but there's actually no underlying disease. And in women, sometimes we find that, especially the regular routine stress ECG testing, there's a much higher false positive rate. The false positive rate in women is about twice what it is in men. It's still low, it's still about 20%, but in men, the false positive rate is lower, it's about 10%. And then, of course, there's the bias that is built into the system, the systemic bias that sometimes women themselves don't present, they minimize their own symptoms, and even when they do present to their doctors, there may be a subconscious inherent bias to believe that they're less likely to have heart disease and maybe not to work them up as extensively. There are other things the other very interesting thing is that women also present with particular types of cardiac issues that are much more common than in men. Not the ones that we talked about, but rare types. One is coronary vasospasm, where the artery itself goes into a sort of a spastic, there's not a clot or atherosclerosis, but the artery goes into a sort of a spasm and blood can't get through the vessels. The other is spontaneous coronary dissection. And this is when the artery tears without plaque or a plaque rupture. The artery itself just tears. And actually, sometimes that happens in young women and even childbearing age or post-pregnancy. And then stress cardiomyopathy seems to be overrepresented in women. We talked about that. All right, of course, we're going to talk about South Asians. And I think there's a relatively high understanding that in the South Asian community, heart disease is somewhat overrepresented. And Dr. Deema, I think, is probably more of an expert at this because I know he's been studying and researching it for decades than I am, but there are various theories about it that basically boil down to genetic and environmental factors. The genetic factors, we believe there's more of an expression of certain chemicals in the body that promote atherosclerosis. And these are some of them that they're interleukin 6, ApoB. You might have read about these also in the paper or magazines or seen it in blogs about heart disease. Lipoprotein is little a is a common one. ApoB, all of these things which are sort of markers for cardiovascular disease seem to be overrepresented in South Asian communities. Why they're overrepresented? Probably something to do with our genetics and some of the environmental issues. There seems to be more predisposition to diabetes and hypertension in South Asian communities. But I should also point out that it's not just South Asian communities. It's also in other ethnic groups, Native Americans, Latin Americans, Filipinos, Middle Easterners, and Black Americans also have elevated cardiovascular risk. Okay, so how do we make the diagnosis? We talked a little bit about false positives and how we diagnose heart disease. Well, no test is perfect, right? So the way we make a diagnosis in medicine is we take a history, we examine the patient, and we do appropriate testing as indicated, depending on the patient's risks and their symptoms. And in heart disease, we use multiple tests, and many of you may have had these tests, but the basic one is an ECG, which is an electrocardiogram. We talked about the electrical wiring of the heart, and that just is a way to look at how the conduction of electricity travels from your native pacemaker, the pacemaker you're born with, your tissue pacemaker, all the way down the conducting system through the heart muscle. Is it happening at the right speed, the right rate, the right order, the right activation? The next one that many of you have had personal experience with is a stress test. And that's where we do the EKG, but we exercise you. So it's not just the resting ECG, but we stress the heart at a high heart rate and high blood pressure. When the demands of oxygen and blood are high, we can see then if the heart is stressed. And very interestingly and fortunately, poor blood flow to the heart is reflected in the way the heart conducts electricity. So when the heart is not getting a good amount of blood flow, especially at exercise when it needs more blood flow, we can actually see an electrical footprint of that. That's what the stress test is. The echocardiogram is, of course, the ultrasound test that people are familiar with because they have ultrasounds of your abdomen, or for women, they have ultrasounds of their babies when they're pregnant. It's the exact same technology. It's ultrasound technology, and we look at the heart. Of course, X-rays. Holter monitor is the monitor that the doctor thinks that you might have an electrical issue, which is intermittent and not always present. And then what we do, we can't capture it on a resting ECG. We put a monitor on you. So it's usually a sticker or something you wear around your neck, and you wear it for a couple of days and sometimes longer, depending on how intermittent your symptoms are. We see if we can figure out what the disturbance is electrically. And of course, there's the blood pressure monitor, because we know that sometimes office blood pressure readings are not really reflective of the true home blood pressure. And we define the blood pressure burden as the blood pressure readings which the patient spends most time at. So, obviously you're usually at home or in the office, so rather than the doctor's office. So that reflects your burden of blood pressure. And the ambulatory monitor is a way to detect, look at your blood pressure, different environments. And of course, if the doctors are worried that there really is something serious going on, they'll send you for a coronary angiogram. That test is done in the hospital. It's usually a day procedure, but you might have to stay overnight if they find something that has to be intervened on. And that's basically where they put a tube in one of the arteries, usually the arm artery now, the radial artery in the arm. They pass the tube up through the arm, all the way up into the heart, and they inject dye directly in the artery. And they visually directly see with X-ray and the dye if there's any narrowings of the artery. And then the newer technology that is becoming very available and useful to us only in the last several years is cardiac CT angiography and cardiac MRI. Yeah, you're familiar with MRI scans. People have them mostly for the brain or for orthopedic issues, but we can also image the heart. It's a little bit more complicated because the heart is moving fast and the images get blurry. So we have super fast scanners and special techniques for the MRI to allow us to visualize moving objects. And we can get very good clarity and definition and see a lot of structural things that we don't see with the other modalities. And here are, of course, pictures of some of them. The top left is electrocardiogram. The top right is a technician doing an ultrasound. That's the sound wave technology. The bottom left is the coronary angiogram. That's, again, where the dye gets injected directly into the heart. And we can see the dye, those snake-like wiggly lines. Those are actually the coronary arteries and all the branches. So we can see the dye going down. And if the dye is held up, of course, then that indicates there's a narrowing. And on the bottom right is the stress test, where the gentleman there has all the electrocardiogram leads stuck on, and he's exercising it, and the technology, the physician is watching the screen. So how about medications? This, this is becoming complicated, and I wish it was easier, but I'll share with you that even for the healthcare providers, the number of options of medications that we can use for all illnesses, but particularly cardiovascular illnesses, is becoming almost unmanageable. I'll tell you, just give you an example. For blood thinners, we probably have 14 or 15 different distinct types of blood thinners. We have, many different types of cholesterol pills. As you know, as many of you know, the most common are statins, but now we have many more different types that are coming on market, which are known to reduce cholesterol and prevent cardiovascular events. One of them is a class called PCSK9 inhibitors, which are injectable medication, not taken every day, but every 2 weeks or every month, and have had a dramatic beneficial effect. Blood pressure drugs, there's 7 or 8 major classes, and each class has, probably 10 different varieties. We talked about heart failure, and now there's specific drugs for the syndrome of congestive heart failure, irrespective of what the mechanism was, whether it's coronary disease, cardiomyopathy, valve disease. Once you have heart dysfunction and the syndrome of heart failure, there are a whole host of drugs that are shown to be beneficial. And many of these overlap with drugs that we use in other conditions. And then many of our, as I pointed out, many of our patients with cardiovascular disease have diabetes. They're very closely linked. And I can't even keep track of all the new diabetes medications. There's probably 7 or 8 major classes, and each one has many different sort of iterations of that class, or different varieties. And then the question is, how do you put all of these drugs together, and how does a patient keep track of it all? And it does become problematic. It does become problematic. So pharmacies use blister packs. We usually, at our clinic at One Heart Care, we encourage people to keep lists, and we categorize them. The pharmacists are very helpful in helping to organize that. But it's really, really, really important for patients to have some idea and understanding of what the drugs are used for. Because when you do that, when the patient understands what the drugs are for, then if changes are made, they understand the rationale for the changes and they can remember them. But I know how difficult it is. I can imagine how difficult it is for patients to remember if they're on 10 or 12 different drugs, and some of them are taken twice a day. I get a lot of questions about aspirin. It's one of the most common questions I get. This is a cartoon I really like. So the doctor's saying to this fellow who probably could use a bit of exercise, he's saying, to prevent a heart attack, take 1 aspirin daily. Take it for a run, take it to the gym, and then take it for a bike ride. So the message there that it's not the aspirin that's doing it, it's the exercise. But aspirin is a critical medication. It is well tested. It has been around for about 2,000 years. People have been using it. It comes from the bark of a willow tree, and it's been commercially available for about 150 years. But here's the catch with aspirin. It doesn't seem to work to prevent the first heart attack or stroke. Doesn't seem to work. But it is very effective in preventing a second heart attack or stroke. So if you've had an event, a cardiovascular event, your risk of having a second event is quite a bit higher. And in that case, the benefit of aspirin overrides the risk. But what is the risk of aspirin? It's not much, but there's a small risk of bleeding and particularly gastrointestinal bleeding, and rare intracranial hemorrhage, or brain bleeding. Any blood thinner can have that side effect. In the primary prevention trials, when we use aspirin in people that have risk factors but no heart disease, in other words, somebody who has hypertension and cholesterol, and maybe even a family history, but if they haven't had a heart attack, it doesn't seem to be protective. In fact, the clinical trials tell us, or seem to indicate, that if you use aspirin in that way, you might be doing harm. So your doctor will tell you that if you haven't already had a cardiovascular event, don't take aspirin. But if you've had one, take aspirin. It seems sort of non-intuitive, but it's just a reflection of the fact that once you've had an event, your risk goes higher, and therefore the cost-benefit equation starts to tilt in the favor of taking aspirin. Okay, so what if we diagnose cardiovascular disease? Somebody has significant narrowings in their heart arteries, or somebody has significant narrowings in the arteries that go to their brain, in their carotid arteries or in their legs. How do we deal with that? Well, there's two major types of intervention currently. One is you've heard of angioplasty and stenting, and that's where the doctor puts it's the same procedure as the angiogram, where they put a tube inside the artery, and over that, within that tube, they pass a wire. And what we do with that wire is over that wire, we pass a balloon, which is deflated, and then inflate the balloon inside the vessel. So you see the diagram on the left, when the balloon is inflated, it pushes the plaque and cholesterol to the side of the vessel. And then in the 1990s, stenting was developed, and that is a metal alloy that goes on top of the balloon. So when the balloon is inflated, the metal alloy acts as a scaffolding and keeps the artery open. And this is a very effective method for opening arteries, and it has reduced the failure rate of angioplasty, from 30% down to about 5%. So when we talk about failure rates, what we say is that after 1 year after your procedure, only with a good-sized vessel and a stent, the current type of stents we use, the chance of there being a recurrent blockage in the same vessel, in the same area where the stent is, in 1 year is only about 5%. Assuming you're taking your blood thinners, okay? And usually when you have a stent, you have to take 2 blood thinners, aspirin, and a second blood thinner with it. The other way, of course, of correcting the blood flow problem, the plumbing problem, is to make a bypass. And that's what a bypass is. Coronary bypass is they take an artery or vein from your arm or your leg or your chest wall, and they bypass it. They plug it directly from the aorta into an area after the narrowing. So they bypass the blockage. That's, of course, surgical and generally open surgical. So for coronary bypass, it's generally an open chest procedure. So patients will always wonder, what should I have, a stent or a bypass? And the doctors will guide you. And there are pros and cons, but generally, bypass is better for particular situations. And those situations are if you have disease in the main vessel, the left main artery, or one of the large vessels, especially disease in the beginning part of the vessel. If you have multiple vessels affected, if you already have heart dysfunction, or if you have diabetes. In those clinical contexts, it seems that coronary bypass may be better. Now, having said that, the technology in stenting is always improving, and there are many trials of doing multi-vessel stenting versus bypass. And the most recent clinical trials comparing those are starting to demonstrate that multi-vessel stenting is almost as good and sometimes as good. But there are particular situations where bypass is better. Sometimes it's patient factors, which we've talked about, multi-vessel disease, proximal disease, heart dysfunction, diabetes. And sometimes it's technical factors, like it's too hard to get a stent in that area, or you will not get good, we call it revascularization, or good restoration of blood flow. The key thing in whatever procedure you have is you want to restore blood flow as much as possible to the normal. So I just want to spend the last couple of minutes talking about some of the advances. And these are really, really interesting. And even in the time that I've been practicing, which is actually now over 25 years, there's been a huge change in the way we approach cardiovascular disease for the better. So we have more medications, as I mentioned earlier, but we also have better techniques dealing with some of these issues. And I say better because they're less invasive, sometimes lower risk, and faster recovery. So here's an example of a valve intervention, which is not surgical. In other words, the patient's chest is not opened. And what happens here is that the intervention is all done through the veins and arteries. So we use the veins and arteries as highways to get access to the heart. And then with particular types of devices and catheters, we can manipulate the heart tissue. And this is an example. So the top one is called a mitral clip in the top picture. And that's where a leaky valve is clipped. You could just think of it almost like putting a paper clip. Of course, it's a medical device which can exist inside the heart. And it clips the leaflets of the valve together. So the valve is like doors that open and close. And if the door is leaking, this clip can actually sort of almost repair that door without opening the chest. The other one that we're doing, and we're doing this one at our local cardiac center, which is Trillium Health Partners, where I work. We do this procedure. And the other example is called a TAVR, transcatheter aortic valve replacement. And this is, so the top clip was the mitral valve. This is the aortic valve. The aortic valve, so the mitral valve often leaks, that's the problem. So we use a clip. The aortic valve often gets calcified and narrow. So as you age, one of the mechanisms that the heart gets narrow is that it calcifies. And as it calcifies, the leaflets get stuck, they can't open. And the heart can't expel the blood from its chamber into the rest of the body. So we put a balloon in there and like a large stent, and we just blow it up and push all that hard calcium again to the side, just like we do it for the coronary artery, and leave a stent in there. And inside that stent is an artificial valve. So it's a valve in a stent on a balloon that's put in the position of the old aortic valve and expanded. And we exclude the old valve, and now you just have the new valve. And these are very, very effective, and we've had a very good experience with them. And then the other thing is, so we talked a bit about maybe non-invasive surgical approach, and this is cardiac devices. So one of the things that we talked about that can go wrong with the electrical system is the heart can go too slow. The heart's not pumping fast enough. People get dizzy and they faint. And when your own pacemaker doesn't work, you put in a artificial pacemaker, which is basically a small little can which has a computer and an electrical and a battery which generates an electrical pulse, which basically activates the heart artificially. So it doesn't depend on your natural pacemaker. And these batteries, luckily, can last for 5 to 10 years before they have to be replaced. And replacing the battery is very easy. It takes only about 20 minutes. So opening the scar, putting a new battery in, and closing it. Pacemakers have become very complicated. Now, we used to just have one lead pacemakers that would just pace one chamber of the heart, and then dual chamber pacing, where you would pace 2 chambers of the heart. And now we have 3-chamber pacing, where we pace 3 of the 4 chambers. And this 3-chamber pacing has been shown to be extremely effective in very particular circumstances, especially congestive heart failure. Because when you pace the heart that way, you get synchronization of heart contraction across all chambers in a very natural way on both sides of the heart. And it's as close as we can get to what we call native conduction or normal conduction. And that increases efficiency of heart pumping, which is the problem in heart failure. And then if all of that fails, we actually have something called a left ventricular assist device, which is when a pump takes over for your heart. And what we do is we basically, in a series, like your cardiovascular system is a plumbing system. So in the plumbing series, we put in an external pump, which augments your own heart, or it can even take over from your own heart. But these are external devices worn on packs. And typically they're used as a bridge to a heart transplant. So if somebody has, very advanced congestive heart failure, they're on all the medical therapy. They're in the best clinics to monitor them and adjust their medications. Then they get all the devices we can put in to fix their valves, to fix their heart electrical conduction. And if they still are very, very limited and they can't function and their lives are at risk, some of those patients will be candidates, and they're very, very particularly selected and carefully selected. because this doesn't work in everybody. It works best in people that don't have lots of other comorbidities, lots of other health issues. But it does save lives, and it can keep a person alive for many, many months until a heart is available for transplantation. So this is the last slide. So what about the future? What does the future hold? Well, we talked about the problem with medications. There are too many of them. And one of the things that is being studied, and one of our actually advisory board members, Dr. Yusuf, has done some research in this. It's called the polypill. And that is the concept of combining different classes of heart medications, like a cholesterol pill, a blood pressure pill, and say an aspirin together, rather than taking 3 separate pills. And there's some evidence that when you do that, compliance is increased. It's easier for patients to take the medications so they don't miss them. The problem is that if you want to adjust, if you have 3 medications together and 2 of them are working fine, but one has to be, the dose has to be changed, you can't change it independently, or you have, you might not, in the polypill, you might not have that combination that you want. Because you can imagine it'd be hard to create a polypill if you had 3 or 4 different medications, each of which has, say, 4 therapeutic doses. Then you're looking at multiple dozens of combinations, or if not hundreds of combinations of different dosing. So that's one of the downsides. How about pharmacogenetics? So what we understand from the clinical trials is that some patients are benefit from particular drugs, but there are some that are harmed. And how do we know that a particular individual is going to be going to have, appreciate a benefit or be harmed? And we don't really actually know that when we use the drug. We're just basing it on the fact that if we treat, say, 100 people, that a certain percentage of those 100 people will be helped, and a lesser amount will be harmed. And also in a lesser amount, they'll have a neutral effect. But what if we could select out the people that will benefit? What if there's way, and there are certain drugs that we know, depending on your genetic profile, will have a particular effect. So maybe we could genetically screen people that would have side effects for a particular drug, and we can avoid harm in those people. How about digital health technology? Well, many of you probably have Apple Watches or some sort of monitoring device that you wear on your body. Many of my patients come to me and show me their Apple Watch rhythm strips. Do I have an irregular pulse? Here's what my Apple Watch said, and they can print it out. It's actually very helpful. And as these digital technologies become more sophisticated and better at screening out noise and artifact, in other words, misreadings, as the devices get more accurate and able to be able to pick up disease more specifically, they'll become better. Right now, there's still a lot of noise, but I have no doubt in my mind that years in the future, these wearable technologies will become more accurate and more useful. And then the question is, how do we deal with all that information? Stem cell therapy. This hasn't really caught on much past the laboratory as yet, but what if your heart was damaged and you had, poor pump, congestive heart failure, your heart wasn't pumping? What if we could regrow heart tissue and implant it, or regrow it in the body using stem cells? As you know, stem cells are the very progenitor early cells in the body that can differentiate into different organs. So if we could take a person's stem cells and encourage those cells to develop into cardiac cells and regrow a person's heart, maybe we could treat disease. And that's still probably decades away. Immunotherapy is using antibodies to target particular things in the body that cause disease. And immunotherapy is being used right now very successfully and very widely in cancer therapy, but not so much in heart disease as yet. Gene therapy. Well, what if we could find a particular gene defect, and we do in certain types of diseases, and what if we could splice out that gene or replace the particular error or the small piece of error in that gene? What if we could substitute it with the correct nucleotide, the correct pieces, the puzzle pieces? that can happen. It probably won't happen in heart disease first. There are other diseases that are what we call single gene or single nucleotide defects, and they can perhaps start with those diseases, and they are starting, and there are clinical trials happening. Heart disease is what we usually think of as polygenic. In other words, it usually isn't just one particular gene defect in heart disease. It's usually a combination of multiple genes. The genetic portion, of course, is a big environmental portion as well. And then how about artificial intelligence? You've been hearing a lot about ChatGPT. The kids are using it for their reports. It's very, very interesting. How much can artificial intelligence help us? Well, I'll tell you, it's going to help us a lot, because we already have algorithms that help us diagnose heart disease. And those algorithms are based on doctors recognizing particular tests and signs. And once we get sophisticated, the algorithms can start to take in much, much more data. Say they can start to take in data from your wearable device. They can take in data from other tests that you've had that, say, the cardiologist hasn't even ordered. Like, say you had a CAT scan 4 years ago for a lung nodule, but something was picked up on the heart, but nobody was looking at the heart at that time. But then 4 years in the future, got a heart problem. And what if we can develop AI that can assimilate all the health information you've ever had together? I mean, it's very hard for a human being to do that. So I think in terms of risk prediction and diagnosis, there's going to be a huge role for AI. I can tell you that the radiologists in our hospital who look at imaging, X-ray images and CT scans, they are already testing AI to look at normal. So in other words, the normal studies, the AI machine is extremely accurate at picking up a normal study. In other words, if they don't see an abnormality, it's highly likely the study is normal. And it's so those, it might, and they're doing a test that do those studies have to be overread by a human physician or not? And it might be that certain tests don't need to be overread by a human physician if the computer is more accurate than a human. So I think the future is going to be very interesting. And I think treatments are going to get better and better and better. And the future is very good. People are living longer with cardiovascular disease. We're learning about how to manage it, not just the lifestyle issues and the environmental factors, but also the medications, devices, and all the things that we just talked about. So I think that's just about it. I think my time's up. I think we'll have a question and answer session a little later so that we can dive into things that people are interested in a bit more detail. And I think I'll be ending the slideshow now. So thank you very much for your attention.
Thank you so much, Dr. Maingi. Your presentation on heart health has definitely been an eye-opener for me in so many ways, as I'm sure it was for our audience as well. I wonder if the Apple Watch sales will now go up. Thank you again, Dr. Maingi. We will have the Q&A session right after our cooking segment, so please stay connected. It is now my pleasure to introduce to you Smita Chandra. You may already know her as our chair. She's a well-known South Asian cooking expert, the author of 3 Indian cookbooks, a culinary instructor, food and travel writer, recipe developer, and a frequent guest on television radio shows. Smita was recently a judge for the Millets Recipe Contest Awards organized by the Indian Consulate and currently keeps busy creating yummy, mouth-watering South Asian recipes for Nestle Canada. Smita has also worked for the Heart and Stroke Foundation of Ontario, creating heart-healthy Indian recipes. I would now like to invite you all to join us in the kitchen as she shows us how to prepare a heart-healthy dish.
I am going to show our audience how to make a heart-healthy, oil-free chana masala or a chickpea stew. Now, this is a really popular dish at home and in restaurants. Everybody loves it, but what often happens is it becomes too loaded with oil and fat or ghee. So today I'm going to show you how to make it completely oil-free without taking away any of the delicious flavors.
Wow, that sounds really interesting. And chickpeas is such a versatile food. I think it's found in every cuisine. So, can you tell us what other ways can we use them? And our viewers would love to know, apart from the stew, how else could they use them?
Absolutely, Tina. Chickpeas are like so delicious. They're such a powerhouse of nutrition and fiber, and they're so good for heart health and for health in general. So you can use chickpeas in so many different ways. You can throw them in salads, in soups, in stews. I like to make chana chaat. I like to put chickpeas even in my rice pilafs. When I'm roasting some vegetables, I throw in a handful of cooked chickpeas so they become nice and crispy. Really, I would recommend our audience to think outside the box when it comes with cooking with chickpeas, because you can't go wrong. They're so delicious, and there are just so many ways of using them.
And how are you going to make it heart healthy?
So what I'm going to do today, Tina, I am going to take away the frying step. There will be no frying of onions, ginger, or garlic to make our chana masala. And I will not be garnishing it with fried onions on top or drizzling some ghee on top, which is also a common practice. But I promise you, we won't be losing any of those delicious flavors.
Wow, this sounds really exciting. So let's get cooking.
Let's do that. I am going to start by showing you some cooked chickpeas. So what I have here are chickpeas that I soaked overnight and then covered them with water and cooked them for about an hour, hour and a half till they're really nice and soft and tender.
Wow. And what about using canned chickpeas? Because, you know, being a busy mom, I often resort to canned chickpeas.
And I don't blame you, Tina.
Yeah.
The thing with canned chickpeas, it's fine if you're in a rush, but really if you have the time to soak them and cook them properly in a pressure cooker or an Instapot, I know everyone's got one of those in their kitchen these days, it is so much more healthier because the liquid that the chickpeas is cooked in is liquid gold. It's full of nutrition, it's full of flavor, and when we mash the chickpeas a little bit, it's also going to thicken up our sauce for the chana masala.
Oh, good to know. Very informative that the cooking liquid has so many nutrients, and I'll definitely try to incorporate time in my schedule so I can soak and make them. Thanks for the tip.
I know you have an Instapot, Tina, and I know you love using it. So this is the perfect way to use either a pressure cooker or an Instapot, or if you don't have any of those, then just cook it in a saucepan till the chickpeas are really nice and tender. So what I'm going to do now for our chana masala, Tina, I am going to show you how to gently mash up these cooked chickpeas. And what it does is it opens them up to the flavor of the sauce and the spices. So when we add all the spices, it not only thickens the sauce, it helps absorb them a lot better.
Well, what a cool tip to mash them to thicken the sauce. Very nice.
Now we're going to add our spices. So I have here my spice tin, and I'm going to add a lot of these spices. So I'm going to add a little bit of dhania, which is ground coriander seeds, some jeera, which is ground cumin seeds, some chilies. Tina, how hot do you like your chana masala? Is that too much?
I love it hot. I love it hot.
I'm going to throw the whole thing in.
Awesome.
Some garam masala. And I'm going to add a little bit of dried fenugreek leaves because they give the chana this lovely curry aroma. It just makes the chana taste so much better. I am going to add some ground fennel. Now, all of these spices have flavor benefits, of course, but they also have health benefits. So they all help to improve our metabolism. They help us digest the food better. And of course, they just taste so great. I'm going to add some ground ginger, which is just dried up ginger as well. Now, Tina, if you notice, we're not putting any salt in here.
Yes.
Because salt, the less salt that you eat, the better it is for your heart health. So we're not adding any salt here, but I find that all the spices that are going into the chana, they add so much flavor to it, you won't even miss the salt. So now, Tina, this really needs to cook for over an hour, like an hour and a half, 2 hours, so that the spices mellow out into the sauce, the chickpeas absorb the spices, and the whole thing becomes one big delicious dish. since I'm not going to keep you waiting 2 hours for your chana masala, I have some ready already.
Wow.
And I'm just going to switch it out. So what I have here is the same chana. It's been cooking for an hour and a half. And notice how it's thickened up a lot and it's absorbed the spices. It's changed color. It's become fantastic.
And it smells incredible. Oh my God, this is so good.
Thank you.
Our viewers are going to love this. I love the way it looks and it smells. It's wonderful.
Wait till you taste it. So now this has been cooking for almost 2 hours. I'm going to show you what it looks like. See how thick it's become. And I've mashed it as it cooks so the chickpeas really soften into the sauce. Now it's ready to eat, but we need to add the final touches to make it even more delicious.
Oh my God. More delicious than it looks and smells. Wow.
So thank you. What I'm going to do is add this beautiful chopped fresh salad into the garam warm chickpeas. And what happens is the heat from the chickpeas will wilt the onions and tomatoes and herbs and draw the flavors into the sauce, making the chana masala even more tasty. So I'm going to add our onions, red onions, tomatoes, coriander, and mint. The final touch, now I've saved some salad, which I'm going to use to garnish it later. But if you really love salad, you can just serve it as a side dish as well. So you've got chana masala and a salad on the side. Now, Tina, the final touch is a little bit of fresh green chutney, if you have any sitting at home, and a little bit of tamarind chutney, if you have some sitting at home. Use it by all means, because it really adds a wonderful taste to the chana masala.
Wow, this is the third dimension.
Third
You're
dimension.
a multi-dimensional chef.
This is a multi-layered dish. So a little bit of the green chutney. And this is completely optional. You don't have to do it if you don't have it. And now we're almost ready to taste. So Tina, your turn. Tell me what you think.
Wow, I can't wait.
I'm guessing you like it.
Oh, I don't know what to say. It's so good, viewers. All I can say, I cannot believe that this chana masala has no oil. It tastes even better than the regular chana masala with oil. So please try it, and amazing.
Thank you. Thank you so much. Thank you for watching.
So there you have it, audience. This chana masala was to die for, and the recipe is available on our website. So please feel free to download it. And now I would like to move on to the Q&A part of the webinar. So I would like to invite Dr. Sudhi to moderate the Q&A along with Dr. Manish Maingi to answer the questions. And Dr. Maingi, I'd like to share quickly the poll results that we had at the beginning of the presentation. So basically what we found is 85% of the audience is concerned about their heart health, and about 57% of the audience members have a family member with a heart condition. So if you could speak to that as well.
Yeah, well, those are remarkable numbers, and I guess it goes to show us the prevalence of heart disease and how it really touches almost everybody. And it is one of the things, I guess we all have to, unfortunately, the way God or nature made us, we don't live forever. So we all have to succumb to something. And the two most common things that people succumb to are cardiovascular illnesses and cancer. And when we talk about premature death is really what we focus on trying to prevent. And there is a lot of, preventable premature death in because of cardiovascular disease. So I think it's something that is on people's minds, obviously.
Thank you.
Well,
over to you.
thank you very much, Manish, for your beautiful, beautiful talk. And extremely useful and very good detail.
Yes, and
A lot of great
thank you
information.
for messaging me so I corrected my slide presentation. I should be
You're
better at
welcome.
this, but I appreciate your
Yeah,
tips.
we have these technical problems every now and then. There's a host of questions, Manish, and you can almost have another seminar. And so I have to be a little selective. But some of the important ones are like, why do young people who are healthy, exercising, eating right, still get heart attacks?
Most of the type of sudden cardiac, or usually that's not a heart attack. Usually it's a cardiovascular event. The term, and I think somebody might have mentioned this before, that the terms heart attack and cardiac arrest are related but very distinct. And in young people without risk factors who have sudden cardiac death, often the mechanism is not atherosclerosis and coronary thrombosis. Sometimes it is. Sometimes people have a very particular genetic defect, which makes them very prone to premature cardiovascular disease. But the majority of young people, like, we're talking, say, less than the age of 35, who have sudden cardiac death or a cardiac arrest from which they are resuscitated, most of those events are not atherosclerotic. They're related to something else, usually an underlying structural heart disease issue that causes an arrhythmia, abnormal electrical flow. And abnormal electrical flow, unfortunately, can be deadly very quickly, just like a heart attack, because your heart can stop suddenly. And if you watch TV, you'll hear about, recently there was a football player on national television that caught a football, hit him in the chest, and he dropped dead, basically, but he was resuscitated with a defibrillator. That was a cardiac arrest related to an electrical abnormality, which was precipitated by the trauma to the chest. And there are other underlying structural heart issues or electrical issues which predispose some people to sudden cardiac arrest, which is not atherosclerosis. So that's probably most of it. But there are, unfortunately, some people that develop standard atherosclerosis. And sometimes it's just, it's a question of just an unfortunate series of events where somebody might have a low plaque burden, not a lot of atherosclerosis. Because everybody, the autopsy studies of people that die in their 30s and 40s from car accidents, when we do autopsies on them, we understand that even at the age of 35, most individuals have some mild element of atherosclerosis. But just very unfortunately, even though their disease burden is very mild, there was a plaque rupture and a clotting cascade that happened. And sometimes it's just unpredictable and rare, unfortunately.
Yeah, thank you for that. I think you're referring to the long QT syndrome and a few
Right.
other arrhythmias that can happen. One important question I think that came up was periodontal disease and cardiovascular illness. The connection. Can you elaborate a little bit on that?
Yeah, that's very interesting association, which is definitely been observed, that people that have periodontal disease do have a higher incidence of cardiovascular disease, atherosclerosis type. And the reasons aren't clear, but it is linked to underlying inflammation. So any chronic inflammatory condition in the body seems to activate these, the biological ingredients for clotting. So in periodontal disease, there's inflammation of the gums. And when there's inflammation in the body, certain chemicals are released. And those chemicals seem to promote atherosclerosis and clotting. So it's not just periodontal disease, but people with rheumatologic illnesses often, say, for instance, Crohn's disease, rheumatoid arthritis, there's many systemic diseases which are inflammatory in nature. And all of those inflammatory diseases are associated with a somewhat elevated risk of cardiovascular disease.
Thank you, Manish. There were many questions about strokes, and I guess it's all part of the vascular structure and the vascular risk factors. Particularly the question about why strokes are more common in certain groups and what can precipitate a stroke as opposed to a heart attack.
Well, that's a good question. I mean, the groups that are at risk of stroke overlaps almost identically with the group that's at risk for heart attack. So all those risk factors that we talked about for heart disease, smoking, diabetes, cholesterol, hypertension, genetic factors, all of those risk factors are similarly risk factors for stroke. Now, why one would get a stroke versus a heart attack, and why one would get atherosclerosis in their carotid arteries in the neck, say, which feed the brain, versus the coronary arteries, which feed the heart, it's actually not that well understood. One particular mechanism for stroke seems to be hypertension. So having high blood pressure seems to escalate your risk for stroke much more significantly than it escalates your risk for coronary events. So one thing we know is that to prevent stroke, good blood pressure management, and sometimes it requires 1, 2, or 3 medications for blood pressure, is very effective. More effective than, in other words, reducing the blood pressure has more of a positive effect on stroke prevention than it does on heart attack prevention. So there is somewhat of a stratifying factor there, but generally it's the same risk factors, maybe to different degrees. And why one would get a heart attack versus a stroke is not exactly clear.
Well, thank you, Manish. One question related to women who take HRT or hormonal replacement therapy. And are they more at risk, number one? And the second thing also related to women who take calcium. What are the factors that can influence heart disease, either hormonally or large amounts of calcium?
Yeah. The hormone story has changed over the decades. When I started practicing, in the 1990s, we thought that hormone replacement therapy in postmenopausal women had a protective effect based on observational studies that were done in the decades prior, but it subsequently became understood that those studies were contaminated, and there were certain biases in those studies. And it turns out that hormone replacement therapy actually is probably does escalate your risk a little bit. Now, in premenopausal women who are using hormones for other reasons like menstrual irregularity, etc., we do know that there's a slightly increased risk of cardiovascular disease. Now, the newer hormone treatments in that population are a much lower dose of hormone. So the negative effect or the incremental risk now is much less than it was because we're using much lower doses of hormone. In the postmenopausal population, yes, it does escalate the risk slightly. But again, I think because the obstetricians, the gynecologists are using less lower doses, that the risk is less significantly elevated. The calcium story, unless you're using very high doses of calcium, there's probably not much of an effect on calcification. The calcification in the coronary arteries is more related to inflammation that's happening at the level of the endothelium, that lining of the heart. That inflammation chronically causes calcium deposition. It's not as tightly linked to serum calcium or dietary calcium, although some studies show that if you're taking high amounts of, very high amounts of calcium, that there may be an escalated risk of cardiovascular calcification or coronary calcification. But those studies aren't that robust. Calcium is mostly from inflammation in the artery, which is the whole idea of atherosclerosis, endothelial dysfunction. And all of the risk factors that we talked about, diabetes, smoking, hypertension, the target organ, the target for all of those risk factors is the lining of the coronary artery, the endothelium, cause endothelial damage. And the damage causes the inflammation, and the inflammation causes the calcification. So not so much dietary.
Okay. Thank you, Manish. So there are again some questions about COVID, young people getting it and going on and on and on, like a long COVID syndrome, day-to-day life being impacted, unable to work, fatigue, etc. Has there been any intervention that can help people like this?
Yeah, the long COVID syndrome is very difficult and frustrating for patients and for the healthcare providers. Most of the symptoms, as you described, Cindy, are cognitive and neurocognitive symptoms and fatigue. Those are the main ones that are very debilitating for some. There are not many chronic cardiovascular complications. There are a lot of acute complications, cardiac complications, which we discussed in the talk, the myocarditis particularly. But there are not that many chronic cardiovascular complications, but the main ones are profound fatigue, neurocognitive, difficulty concentrating. And I have several patients that have contracted COVID who have it. Not just patients, but actually there are several health workers that have it. And I'll tell you, in the hospital, we have several nurses and allied medical workers who are suffering from long COVID, and they haven't been able to come back to work. And it's very hard for them because they're very motivated too. And they're doing all the things that they're told, the physiotherapy and, good sleep, good exercise. But it just seems that they're not able to regain functional, their pre-morbid functioning capacity. Before they haven't been able to regain their functioning the way it was before they were sick. And it's taking a long time. And there's a lot of research going into it. I wish I had an answer. There's no particular intervention. It's just time. The good news is all the studies on long COVID seem to indicate that with time, gradually, more and more people start to regain their level of function back. Now, it's only been a couple of years of data, but over the last 2 years, when we study those patients, more and more and more of them are regaining function back to baseline, but maybe they won't get 100% back.
Right. That in itself is a topic on its own, as you suggested.
Yeah. And I'm no expert on long COVID.
There were many questions about, various interventions and how they work, but I think you covered a lot of that in your talk. And in the interest of time, I think we need to move on because there were 2 questions for Smita as well. I don't know whether we can get Smita into this as well. So the one question was, how can you make non-vegetarian food more heart healthy? And the second one is, what is wrong in using a little bit of oil in your chana? It will improve the taste even further. Mind you, I've tasted your chana masala and it's outstanding. But there was a question from the audience, is it okay to put a little bit of oil and make it even more interesting? So very quickly, if you can answer those 2 questions, please.
Sure. Thank you, Dr. D. I will start with the chana masala question because it's still fresh in our minds after watching the video. The whole point in maintaining heart health is to cut down on oil consumption, fat consumption, and that is why there is no oil in the chana masala. But I'm sure Dr. Maingi will agree with me that it's quite okay to add a little bit of oil if you feel it's going to improve the flavor. Sure, why not? Go ahead. And to answer your other question, Dr. D, how to make non-vegetarian food heart healthy? I think the cooking method is very important. Don't cook it in a lot of oil or fat or ghee or butter, as we discussed with the chana masala. It's better to roast it or broil it in the oven or bake it, and trim off all the fat before you cook it. And if you've cooked it and there's a lot of fat that's skimming on top, then take the fat off, skim the fat off the top of your mutton curry or whatever you're making. But in general, I think Dr. Maingi will agree with this, right, Dr. Maingi? It's best to avoid eating too much red meat if you want to have a healthy heart.
Yeah, I agree completely, Smita. There's nothing really intrinsically unhealthy about non-veg as long as you limit red meat and you use lean meat, just like Smita said. So in fact, the risk of being vegetarian, which I remind my vegetarian patients, is sometimes the risk is that you consume too many simple carbohydrates. So if you're a vegetarian, be very, we have to be conscious not to consume too many of those things, the rice and the simple breads, etc., that have high glycemic index, because these enhance the risk of metabolic syndrome and diabetes and so forth. But for meat itself, if you're avoiding too much red meat, there's no cardiovascular risk, and if you're avoiding too much fat.
So the trick is to
Well,
have
thank
more
you for
fish, chicken breast, and stuff like that.
Yeah.
Thank you for answering those questions. Quick answer, Manish. If you have a pacemaker, will it interfere with the MRI or vice versa?
Yes, it will, because the MRI works on very high, powerful magnets. Anything that would be attracted to a magnet would be dangerous to take into an MRI. But the good news is the new MRI machines are made of different alloys, which are non-ferrous. They don't have iron in them, and they're not attracted by magnets. So, and it's just, this is literally 2023 now. So the newer devices we're putting in are MRI compatible. But our radiologists are too afraid to try it. But by next year, we'll be doing it because the devices now are all well tested. So in the future, you can have an MRI when you have a device, like a pacemaker device.
I think there are a lot of questions on angina, on aneurysm, strokes. Some of them very personal questions as well about they've shared some of their experiences, and it's going to be very complex to answer these questions. Some of these have to be done by a neurologist, I believe. But there was another question that I think I could answer very quickly. And why are South Asians more at risk? What are the lifestyle implications, or what are the factors? So we know that intra-abdominal obesity, the waist-hip ratios in South Asians is much bigger than, or more than, the general population. Second of all, that intra-abdominal fat acts as an insulin resistance, and high insulating levels will raise a thing called triglycerides, which will raise your blood pressure, raise your blood sugar, and reduce your good cholesterol. And this cascade of events is called the metabolic syndrome. I think those are one of the main things. Secondly, South Asians tend to eat more salt, they tend to eat more sugar, and they're less likely to exercise. They rather watch cricket than go and play. And we do a lot of things around food. So I think very quickly, there are a multitude of risk factors why South Asians are a little bit more higher with heart and diabetes, but those are the main ones. So I think I want to thank Manish, I want to thank Smita, and we had a good Q&A session. The people whose questions have not been answered, I will either try to answer them myself or pass them on to Manish and get some way in which we can do that. So I'm now going to close the Q&A session, and I'm going to hand it over to you, Smita.
Thank you, Dr. D. And hi, everyone. Thank you for attending the webinar. I hope you enjoyed it. Dr. Maingi, thank you so much for sharing your knowledge with us, for that illuminating talk with wonderful slides. And it's left us feeling very reassured that there are so many new medical advances to take care of us. So I, for one, am feeling much better about this. Thank you, Dr. D, for introducing a new Tamil word to our vocabulary, our ever-growing vocabulary, and for moderating the Q&A. There is a lot that goes on behind the scenes, and our executive team works really hard to bring you these informative webinars. I would like to thank our charming MC, Tina Valia, for hosting the webinar and for being my co-host in the kitchen That was a lot of fun, and that was a change of role for both of us. I would like to thank Sridhar Rao for his tech and Zoom support, Dr. Asha for extending our outreach into the community and helping promote our webinars far and wide, and for running the slides and videos during the webinars. Ashima Jain for securing corporate funding, Rajiv Prasad for printing, design advice, Sanjeev Chandra for filming and editing of the cooking video, and Ashna Roy for creatively designing our flyers and slides to make them bold, beautiful, and eye-catching. Now I have a very special shout out to Barbara Wally and Gary Douglas, who have been our loyal supporters and generous donors since the very beginning. And we have the photos to prove it. Here is our youngest volunteer, Ayush Rao, at age 4, selling them raffle tickets very successfully, I might add. And here's Ayush at age 11, watching the webinar. In fact, he was the one who asked the chana masala oil question today. And for someone who's 11, he's very savvy in the kitchen, I can tell you that. Thank you, Ayush, Barbara, and Gary. We appreciate your wholehearted support. If you have enjoyed our presentations and would like to support future webinars, please donate to our outreach through our website, www.trivo.org. And we would love for you to please answer this very simple poll in order to help serve you better. It's a really quick one and will take you just a few seconds, but it will help us tailor our webinars so that we are better suited to meet your needs and answer all your questions and concerns. Now, we would also love your feedback about how we're doing and what else you would like to see in future webinars. We're going to take a brief hiatus during the summer, but we promise to be back in September with a whole new array of webinars. And we thank you so much for your support throughout this long COVID situation when we started our webinars 3 years ago. Thank you once again for spending the evening with us. And I will now hand it over back to Tina.
Thank you very much, Smita. I hope the audience has enjoyed our webinars as much as we have enjoyed putting them together for you. And I hope you enjoyed the cooking segment. This was our first time introducing a cooking segment. So we would love your feedback. And we hope to bring many more interesting segments to you in the future. So on behalf of the Women's Outreach Wing of the Ripple Effect Wellness Organization, or TRIVO, I would like to thank you all for attending the webinar tonight, as well as earlier in the year. We hope you have an enjoyable summer and you stay safe and have a good time with your family. And we hope to see you at our next webinar in September. We wish you a very good, happy good night and stay safe. Until next time.